So as Dr. Kaiser said, my name is Dills. I'm an HIV systems consultant with the State Department of Health. I am the best systems consultant in the state because I am the only one in the state, because I made up the name. You want a fancy title? Give it to yourself. So I am here today to talk to you about a lot of data, so I'm going to have a couple more slides than they were supposed to allow us to have. So I hope you'll forgive me for that. But we have a lot to talk about, so let's get right into it, right? So I'm here to talk to you about how we as a community are going to end HIV, right? Because that's why we're all in the room. We're all here because we want, and we've dedicated our lives to ending this epidemic, right? And it's a very simple three-step plan on how we're going to be able to do that as a community. So first, we're going to talk about preventing new infections. And there's a couple of new technologies, new scientific advances that have come out and been proved in the last few years that's going to allow us to do that. And we're going to use this concept of status neutral to talk about how we're going to prevent new HIV infections. Now, this idea is a relatively new concept. It comes out of the New York City Department of Health, and they talk about how we can neutralize our HIV status in regards to risk transmission. And there's two ways that we're going to do that. One, we're going to do through PrEP, and one we're going to do through TAS. So we're going to start with PrEP. And I know everybody here has heard about pre-exposure prophylaxis, right? So pre-exposure prophylaxis, we know studies have proven if we are on daily PrEP, we're going to have a negligible risk of acquiring HIV. Right? So this is amazing technology and amazing advances for us in regards to HIV prevention, and it kind of changes everything in how we talk to our communities about HIV. Second, we're going to talk about treatment as prevention. Now, the idea of antiretroviral treatment isn't a new concept. We've understood for a while the impact of medications on viral suppression and the impact of viral suppression on individual health. But up until recently, we haven't understood the impact of viral suppression on new HIV infections. And we know now that sustained viral suppression prevents me from passing the virus on to other people. I have a negligible risk of transmitting HIV. So people at risk of HIV taking daily PrEP and people with HIV with sustained viral load suppression do not acquire or transmit HIV, period. Undetectable equals untransmittable. And these advances change how we talk about HIV in our communities. It helps us remove a lot of the stigma that we put on our community members, especially in regards to promoting sexual health. So this is going to be amazing. This is how we're going to prevent new infections. Second, we're going to make sure that we're providing equitable access to care, okay? Now, we've talked a lot in the past about, and I'm sure these memes are something that y'all have seen before, the differences between equality and equity, right? So when we talk about equality, equality says we give everybody that comes in the room the same thing, and we assume that giving everybody the same thing is going to grant them access. Now, does that grant everybody access? Is everybody coming into the room with the same resources? No, we understand, looking at environmental context, social determinants of health, that people come into the room with different needs. Okay, so we need to focus on the concept of equitable care, right? We need to understand what people need in order to achieve access to care and provide that to them, not giving people more or less than what they need. Now, this idea of equality and equity is oftentimes based on individual behavioral characteristics. In this case, we're trying to achieve equity because that one guy, the little shorty on the right, can't see over the fence, right? So that's what we're doing in our daily work, is trying to work with people on their individual behaviors to help understand what kind of equity they need to achieve access. But what's the biggest barrier in this picture? It's the fence, right? And so our job, while we're working to achieve equity, is to understand those structures and those institutions that create barriers for our clients and to start tearing them down. And in our system, that looks like a lot of different things. But if we want to take a broad view of it, it looks like institutional racism, institutional sexism, institutional ableism, right? Our clients come into the room with a lot of layers of stigma oftentimes attached to them. And our job is to understand those oppressive structures and start tearing them down. Now, our third step on how we're going to prevent to end HIV is prioritizing those populations with higher burdens of care, higher burdens of infection, and increased barriers to care. Now, this is going to look a little bit different around the state and different regions, and we'll talk about that in a minute. But when we're looking at the state level, this is generally how it tends to play out. For every 10 people living with HIV, 2 are Latino MSM, 2 are white MSM, 2 are black MSM, 1 is a black female, and that's the data that we're able to collect is on these populations. We have a 5th priority population, our transgender community. At this time, we don't have enough data to be able to accurately reflect this community and talk about them. Only a couple of our data systems have been capturing this information for a while. But we are going to be collecting this information in all of our databases now and moving into the future. So in a couple years, we'll be able to better talk about this community. We're moving to a two-step question for gender. What's your sex at birth? What's your current gender identity? And in the future, we'll be able to talk about this community. But for the rest of this presentation, we're only going to be able to talk about the data for these first 4 populations. But I want you to keep in mind our transgender communities and the pathways that they need to move through our system of care. Now, we don't include age as a separate priority population, but we do know that HIV impacts different generations differently. Now, 5% of all people living with HIV in the state of Texas are under the age of 25, but we look at new diagnoses, 1 in 4, 25% of all new diagnoses are among people under the age of 25, and this is a trend that's been in place for a while. Not just that, 60% of all new diagnoses are people under the age of 35, right? And that's our millennial generation. And when I start thinking about different generations and how they move through care systems, I start to think about my mom. My mom's 70. When she gets reminder cards from her doctor, she puts them up on her mirror so she can remember to go to the doctor. She likes getting the mail. She sends me mail. She just started texting 2 years ago. So the way that she needs to be communicated with as she enters into and moves through the care system is going to be vastly different from how a 20-year-old moves through the care system. Do you think our 20-year-old clients are opening letters and reading them, or even answering the phone, or looking at their voicemail? So we have to make sure these are some of our low-hanging fruit. Just this idea and thinking about who's moving through our systems, we have to start looking at those pathways that they're on and making sure that the way that we're approaching them and engaging with them is a way that's going to be reflective of who they are. So that's how we're going to do it. Those are our 3 steps. We're going to prevent new infections. We're going to ensure equity to ensure access to care to achieve viral suppression, and we're going to prioritize those communities who have higher burdens of infection and increased barriers to care. So now that we kind of know who we're looking at a state level, let's zoom in a little bit more on a Texas level. Now, this is a lot of information going on in this slide, and we're mainly trying to get an understanding of how our priority populations look different in different parts of the state to show that one system of care can't work in the country of Texas, right? And Texas is a country. That's what I learned when I moved here 10 years ago. It's actually 7 different states, right? And we can kind of see that reflected here in how our priority populations are broken out. For example, when we look along the border, the US-Mexico border, we can see that their HIV community is largely in the Latinx community, especially Latino men who have sex with men. In Laredo, for example, there's no black women known to be living with HIV, and there's only 4 gay black men known to be living with HIV. So a system of care that works in Laredo is going to be very different, for example, than a system of care that works in East Texas, where we see larger proportions of black women. So let's look specifically at this region. I was told to talk about Beaumont, but I'm also going to talk about Galveston and Houston, because I don't think you can talk about Beaumont without looking at the other areas around. So we can already see that Beaumont and Galveston look very different. There's significantly larger communities of black gay men and black women living in Beaumont compared to Galveston, where we have a much larger community of white gay men. And we can see that Houston also has larger communities of black gay men and black women as well. So a system that works in Houston and a system that works in Beaumont isn't going to work in Galveston. And that kind of makes sense to us. We can see how these communities would interact and engage with the care system in different ways. And up until now, we've kind of offered everybody a one-size-fits-all path. And we know that that doesn't work. Equal treatment doesn't work. The other thing we have to take into account with this part of the country of Texas are people who inject drugs. And there's a much larger community of people who inject drugs in the Beaumont and Galveston areas than we see in the rest of the state. The state average is around 13% of people living with HIV acquired it through injection drug use. In Beaumont and Galveston, we're looking at 19 and 20%. So almost 1 in 5 people living with HIV in this area acquired it through injection drug use. So while that isn't a priority population for the state, for this area, it's something that we need to be aware of and understand the experiences of this community better. Okay, we have a few more slides, and the rest of them we're going to look at health outcomes and health data. So there's a couple of measures that we're really going to focus on here. We're going to focus on retention in care, and we're going to focus on in-care viral suppression. First, we're going to start with retention in care. Now, based off the work of Dr. David Holtgrave, we've established some goals for the state, goals that he says if we're able to reach, we'll reach a tipping point and start to see a decrease in new infections. He says if we're able to achieve 85% retention in care, that we'll start to see a tipping point. in that regard. So this map is broken out in that way using the stoplight system, red, yellow, green, right? Green is our 85% or above. That means we're going to go for it. We're going to look for promising practices. Yellow, we're a little bit further away from our goal. And red is where we're in our priority areas. Now, we can already see that there's no region in the state that's achieving our retention goal. And this just isn't a Texas issue. This is a national issue. We're going to see these challenges throughout the U.S. There's tons of conversation about the lack of effective interventions to help people access and retain themselves in care. And so we're going to start seeing a lot of work done around this in the country. And we can see specifically in this region, Beaumont, Houston, and Galveston are all in the red. So this is a priority for us as a state to stop and understand better what's happening in this region. Next, we're going to look at our in-care viral suppression. We talk a lot about community viral load, and that's looking at the viral load among all people known to be living with HIV or all people in the community with HIV. Our in-care viral load is only going to focus on those who are retained in care. That allows us to get a better look at our system to understand what's happening with it. Now, when we look statewide at our viral suppression measure, most regions in the state are able to achieve it. We're creating those opportunities once folks get established in our care system that they can achieve viral suppression, but not every place is. And when we look specifically at this region, both Beaumont and Galveston also are struggling with our viral suppression. So we need to start understanding better the experiences of this community here to know what's happening with how people are engaging with and interacting with our system of care. So we're going to look at retention and care measures for all of our priority populations to see how folks lay out, and so we can start to understand better these disparities in care that we see. And we see this around the state. So we already have our red and yellow that we saw earlier. We understand with our stoplight system what that means. Each of these bars that you see are ranges of retention for these 4 priority populations. And the length of the bars show us already disparities in care. Not everybody is achieving retention at the same rate. So we're going to walk through each of our communities somewhat quickly to get an idea of how different folks fare. First, we're going to start with Black gay men. We can already see that Black gay men don't differ based on region. They're all kind of at the same range, regardless of if they're living in Houston, Galveston, or Beaumont, but we can see that they're all in the red. And in a couple of our areas, they're at the very bottom of the range. This tells us that this is a community that we need to prioritize in understanding their experience with not just our care system, but the healthcare system overall. We know that our communities of color have been traditionally oppressed by healthcare system and other governmental institutions, and so we need to take the time to better understand this community and know what questions to ask to better reflect the needs that they have. Next, we see our Latino gay men. Now, in Galveston and Beaumont, this is a pretty small population. So we don't put a lot of energy or focus into understanding these pathways because they don't have as much impact in our overall community. But we can see, again, that there's not a lot of variance based on region and that they're towards the top part in some of our communities. Finally, next we're going to look at white gay men. And the thing that stands out the most for this picture is that regardless of region, white gay men are at the top of retention rates in every single system. And this makes a lot of sense to us. We talk a lot about how our Ryan White care system is of the community, by the community, and for the community. And when our Ryan White care systems were developed in the late 80s and early 90s, the community that we're talking about were white gay men. So it's no surprise to us that white gay men are able to find more opportunities to achieve retention than our other groups. It tells us that we need to understand who the community is now so that we can better reflect those needs and create pathways and care systems for all of our communities, not just one. Finally, we'll look at Black women, and we're going to see huge disparities with Black women's retention rates based on region too. So we can see that in Galveston, we're struggling more, we have fewer opportunities for Black women to achieve retention in some of our other areas. But in all of our areas, Black women are still struggling to achieve those retention rates. So when we kind of look at it all together, we can start to see how these disparities play out. We can see them play out around race, especially in this region. And we can also see which regions are doing better, where we can start to look for potential promising practices. Not everybody's going to be able to shoot up to green overnight, right? We have to incrementally step our way up. So we can start to get a better understanding of who we can start to look to in this region to know how to ask better questions. And then finally, we're going to look at our viral suppression numbers. Now, like I said, in most parts of the state, we're doing pretty good at creating those opportunities for folks to achieve viral suppression. And in Houston, we can see that pretty much every population there, except for one, is in the green, which means that they're achieving the goals we need to get to for viral suppression. And our other areas, though, were generally below our target point. So we're going to pop them all up there since you already know how the system works. And we can start to see, again, these huge disparities in care. And remember, these are all folks who are considered retained in care by our measure, which means they've had at least 2 contacts with the care system in the reporting year. And even with those 2 contacts, we see a lot of folks not having or not being able to access and maintain care in a way that helps them achieve viral suppression. So as we move forward in doing this work, and we keep in mind those 3 steps that we're going to be taking in order to end HIV, we need to make sure that we're prioritizing these communities when we develop these new pathways. We have to understand that it's not a one-size-fits-all model, and it's time for us to take back our community, right? We've professionalized HIV a lot in the last few years, and it's taken away a bit of our community sense. And as I look around the room, it makes me think about, is our community reflected here? Is our community reflected in the workforce? And when we look around the state, it's not. And so we have to be creative and innovative and find out ways to get more of our community re-engaged in this work, because that's how we're going to end HIV. Not just one individual or one agency, but as an overall state community. Thank you.